Okay, so our last session today is by my friend Sud. Sud is again, correct me if I'm wrong, co-founder of the Center for Health Research and Education. And his presentation is called Bridging the Policy Practice Gap in Tobacco Cessation.
Bridging the Policy Practice Gap in Tobacco Cessation. I am Dr. Sudhanshu Patwardhan. Here is my declaration of interests. Tobacco cessation policies at a global level and even at some national levels are great. The World Health Organization's Framework Convention on Tobacco Control has an entire article, Article 14, dedicated to tobacco cessation and tobacco dependence treatment. Nicotine replacement therapy, or NRT, is on the WHO's Model Essential List of medicines. In the US, the American Cancer Society clearly asks on its website, does nicotine cause cancer? And the answer is no. It also says on the website, nicotine gum is usually recommended for 6 to 12 weeks, with the maximum being 6 months. But it is better to keep using the gum rather than starting to smoke again, it says on the website. Now, come across the Atlantic to the UK, and we see that as far as back as 2010, the UK's Medicines Agency licensed the world's first ever product for tobacco harm reduction, nicotine replacement therapy. The UK government position is clear. There are no circumstances in which it is safer to smoke than to use NRT. NRT can be used as a complete or partial substitute for smoking without a limit to the duration of use. So, tobacco cessation policy underpinned by harm reduction principles in these examples is spot on in this context. However, more often than not, the practice is not. Nicotine replacement therapy is often costlier than tobacco globally, but especially in low and middle income countries where it's not even widely available nor appealing enough. Key decision makers and influencers of patients' behavior and consumers' behavior, for example, media, doctors, civil society, policymakers, often harbor nicotine misperceptions. For example, from a recent survey of over 15,000 physicians from 11 countries around the world, it was found that over 80% of those surveyed wrongly thought that nicotine in tobacco products causes cancer. No wonder many doctors, even in the UK, do not know about the UK's harm reduction indication for NRT, and most doctors I've spoken to around the world are unsure on how to advise patients on using nicotine gums and patches, or about dual NRT for managing acute cravings as well as for withdrawal management during a tobacco user's quit journey. This knowledge gap on nicotine leads to low confidence in recommending or using safer forms of properly regulated nicotine products for quitting risky forms of tobacco. Indeed, there is a gap, and the gap exists between the policies that understand and separate tobacco harms from nicotine's role in tobacco harm reduction, while on the other hand, there are practicing clinicians, lay people, and other stakeholders who harbor nicotine misperceptions and struggle to offer adequate support to tobacco users in terms of adequate nicotine replacement for long enough. All's not gloom and doom. There is a willingness to upskill. For example, a research we had done among healthcare professionals in India a few years ago, we found that on an average, 20% of those surveyed had received any tobacco cessation specific training. However, on the upside, nearly 80% of them were interested in augmenting their cessation ability through bespoke training. So the need of the hour is clear. It is a nicotine information program, a program run by independent, credible, and unbiased experts for all stakeholders who influence consumers and patients' decision for quitting, and using an information sharing, dialogue-based approach. To conclude, decoupling nicotine from tobacco harms is the first step in changing the narrative around tobacco cessation and harm reduction. The range of stakeholders who need accurate information on nicotine is wide. Achieving a world free from the harms of risky tobacco products will need a multidisciplinary and multi-pronged approach. A key building block for all of that is nicotine literacy, enabled by accurate scientific evidence-based information shared by independent, credible experts. Thank you.
Questions for Sud?
Norbert Ziller from German Consumer. The most unanswerable question, how? How do we get the information out?
That's a great question, Norbert, and thanks for asking it. It's a very obvious one, isn't it? For the last 10 years, I've come to these conferences and literally heard the same thing echoed by industry people, by academics, by consumers. And the short answer is it has to be done, as I said, by independent experts. But the how is also equally important. If we try to boil the ocean, as they say, it's not going to work. I am going to say something which may be controversial. I accept saying it, though. There are attempts, well-meaning attempts by some in the tobacco industry to do this in the case of physicians, in the case of clinicians, to go out and do continuing medical education programs for doctors. Now, the intention is good, right? Because clinicians are an important roadblock in terms of advising patients who are consumers of tobacco products. The intention is good, but it has backfired. Yeah? So you're doing some signs there. They will put a 5.3 in front of you. They'll have many reasons to do this, but also there is a sensitivity that has to be understood. At the moment, none of the tobacco companies that I know, at least in this context, who are running such continuing medical education programs, have a licensed medical product. One cannot hijack the existing CME or medical education system for talking about nicotine information. So there are two issues, right? One is, yes, nicotine information has to be given to doctors, but that model which exists for pharmaceutical companies is available for doctors to upskill themselves, get a certificate, get credit points, is not the model. So I've said what is not the model. Now I'll answer your question, which is, still there is appetite mostly around the world where I've traveled, be in LMICs or in the Western world, for dialogues in closed door sessions where there is complete transparency. So if tomorrow a team of us was to say, okay, we're going to talk about nicotine, but provide very accurate information, unbiased, and have a dialogue about it, I can assure you, doctors, media, policymakers in different groups will happily come and listen to it. The challenge, which we have, I think, overcome in the work I've done in the last 5 years, is don't just download stuff on them. Everyone loves to do that. All the consultants who advise the industry love to say, we will do a dialogue for you. Yeah, and what happens after that? They leave. They fly back to wherever they are in Italy or in Greece or in US. You cannot leave those folks just hanging with that information on nicotine. Work with them. If they are clinicians, advise them on how they can advise their patients, starting with NRT because that's legally available. But if you have pouches and e-cigarettes, advise them on how they can support their patients. Go back in a few weeks and months, see what they're doing in their practice, advise them again. For example, one work we did in India with psychiatrists who did not ever ask their patients on tobacco use. We said, first ask them. They came back after months saying, we have asked them. Okay, now give them NRT because that's legally allowed. They gave NRT. After a month, they said, that's not working. I said, well, how much did you advise? Oh, we gave 2 milligram gums. How many times? Well, 2 or 3 times a day. How much was the person smoking? Oh, he was smoking 30 or 40 cigarettes a day. I'm like, okay, so now let's have that conversation. Then we talk about craving management, withdrawal management, dual therapy. We get them on that initial journey on nicotine literacy. Then we come to the point saying, well, if despite all this work, 50% of our smokers are not quitting. Now, this is the point where being a policymaker in the debate and say, look, mate, you have banned e-cigarettes in this country. Your smokers in this country are losing out on an option for quitting. Let's bring that in the discussion. So it's a journey. People want a quick fix. They want a one-off solution. And I'm sorry, the industry is equally responsible for taking a lazy approach. So I think there is a solution, but it has to be an investment in the long run. One final thing, if I may. Thanks for giving me the chance. I did not plant this question. The industry spends a lot of money on sponsoring Formula One type things. If they had spent the same money on doing some of this, we would be in a different place today. Yeah.
Okay. Probably you have answered my question, but we have doctors in Spain, in many countries, that are trying to bring this information to other health professionals in every hospital, in many hospitals. But we face the condemn of the other physicians in the hospital, the condemn of the authorities, the accusation of the health minister. It's absolutely impossible to bring programs to show the reality of science to other health professionals, but including fear of lose their jobs, be expulsed of the universities. I know doctors that passed this thing. Okay, so the same question is how.
No, gratia, Dr. Carmen. I think that's absolutely, and maybe it's good to revisit the answer by saying, look, for doctors, one should resist the temptation to host a big conference, a big meeting, big banners, and then talk about it saying, look, we are doing continuing medical education and something else for doctors. We've done thousands of these doctors in this state and that country. That is not the approach, obviously, because again, you're treading in a territory which is not. This is a consumer good with the potential of harm reduction along with existing other nicotine replacement products. It has to be, go to single individual or a small group of people you trust. It has to be peer-led. If there is one doctor, and maybe there is somebody in this room who is a doctor who is sitting next to you and says, hey, I understand nicotine, I've done my homework, I've tried this on my patients, I've failed, and hence I've learned again and I've gotten ahead on the game with failures and success eventually. I'm going to tell my other peers, no medical professional will listen to a non-medical professional. You need the right peer to tell the right person what the message is. But again, don't leave them hanging or just leave them after one session. You have to hold their hand through the journey. Back to what Marwa mentioned about the mentoring scholarship program. I think all these things take a lot of hand-holding through the journey. You have perhaps through being a scientist, but also, if I may say, with a lived experience, you understand the issues over years. You can't expect people to get that eureka moment in a moment. Yeah, it is just unrealistic. And I think that level of commitment to investment is absolutely crucial to get those folks around. The vilification will continue. They have a business to run. The whole anti-THR industry has its own business and survival to run. But we shouldn't get bogged down by that. I think the solution is to approach it in a humanistic way. So that's what I believe, at least.
Thank you, Sud. One last question?
My name is Ricky. I'm from Pharma. We're part of PMI. I work with consumer insights, and I'm curious to one of the first point you had saying that NRT is not a premium.
Yes, but thanks. Fertin Pharma, I believe, yes, you make NRT products and so on. And do you doubt my statement, or do you want?
Not at all.
Okay.
I support it 100%.
Yeah. So the question is, what can we do about it?
It is, what do you think? What part of NRT is not appealing?
Sure. So one of the experiences I had in my past life before I started the Center for Health Research is when we had looked at some of the data from nicotine gum manufacturers and some consumer data. Look, the flavors you have NRT in could be a strawberry or some sort of a mint flavor, especially for oral consumption. Now, patches, you don't even feel anything. There is no element of appeal there. If at all, it's less appealing because you're kind of putting it in different places. Some people have allergies to that and so on. So it's a hassle. But with gums, very quickly you get taste fatigue. Yeah. So after a while, the flavor and the taste is something that you just don't want. And it's only human for them to not want it. So that element of gum consumption becomes a chore, a boring thing to do. And again, that's where innovation is absolutely crucial. Now, this is kind of it's a slippery slope, mind you. With vaping, you have hundreds and thousands of flavors, and one could argue, well, do we need that many? But for sure, the role of flavors in making something, and look, smoking is an addiction in the case of combustible tobacco, smoking in the case of oral tobacco, these are addictions that are not easy to get over in a day. Withdrawal symptoms can last for a few months. craving relief will perhaps, and we've got experts here, so I shouldn't try and pretend I know everything about cessation. But what I know, at least 4 weeks of solid support with nicotine replacement, up to 12 weeks, and in many cases, much longer. Because those cues you get in a social function and somebody is lighting up a cigarette, suddenly everything comes back. And you want to have some way to manage your craving. So a gum may not meet that. So you need a combination of products. I mentioned dual therapy earlier. So again, that's something that the UK has pioneered in terms of approaching, accepting. And we do see success with a combination of a gum and a patch. If you have electronic cigarettes properly regulated in a country, make sure that's available. Yeah, understand the dynamics of how nicotine is required by the patient and ensure they get it in the right time.
Okay. Time up, I'm afraid, Roberto. Apologies.
Very quick.
Carry on over the lunch break. I don't want to delay people from their lunch. Look, I'd like to thank our presenters today and also thank the authors who couldn't make it today. So thank you very much.